and it's all extremely important. But as I've gone further in my career, the more my hands are on rib cages.
The more what? The more what?
The more my hands are on rib cages as I've gone through my career. It's not just manual, but testing. And not only does it help me, with where I'm stuck with the patient, but the patient's really, some patients are very in tune, but when they can't breathe, they get it pretty quick. When they can, they get it. So, it definitely helps with patients too. So the more I've done this, over is important, and looking at shoulder rotation is important, definitely, but the more you can assess that rib cage movement, the better I've been as a clinician in my career, for sure.
And Kurt, when you start PRI, for the people in the room that are just taking their first class or two, or the people at home taking this home study course, if they've never ever understood anything about PRI, we had to use some tests that we got as clinicians or non-clinicians called tests that we could correlate with, and I like the word correlation, that we could correlate to get jump started, right? If we really, to be truthful about it, I don't know if you and I would even want to talk about adduction anymore. Are you with me on that, Kurt? I don't even know if we would want to talk about extension of the hip anymore, right? But remember those early days? It's what plugged you in. There's a change there. I only heard the sighs going, oh my gosh, you can actually internally rotate his arm. I'm not sure you and I would even want to talk about internal rotation of the arm right now, right, Kurt? There's other things that we're looking at that are significantly as, if not more, important than those orthopedic tests. You are seeing the trees in a forest because of the tree that you're standing by that taught you things look and sound like those trees. But there's different forests out there. There's people out there that look at nothing but physiology, and this complements that. There's people called ENTs that look at nothing but how you move air in and out of oral airways or orifices, and et cetera, et cetera, et cetera. I won't go through all that. But the comment's really good, and I appreciate you bringing it up, because you're saying now, as I get more advanced and more enhanced, I'm really looking at what? Ribs. Kurt, I bet you've heard a few pops in your life, haven't you? Huh?
Yep.
Yeah, and they heal, don't they?
Oh, yeah.
And do you regret not doing that?
Oh, no.
I just want everybody in the room to understand that. Remember yesterday how excited I was? I'm trying to make a point on this. Yesterday how excited I was when I said, Heather, I was looking around the room, and what did I see everybody doing? They weren't afraid of what, Daryl? They weren't afraid of ribs. That's a cool thing. You guys got a great class. You aren't afraid of ribs. That's the message we're trying to say. You're not going to hurt somebody. You're not going to hurt somebody with ribs, even if you hear a pop. You're going to hurt them if you don't. You follow me? In our humble opinion. That's why when I look at this picture on this slide, see this guy's curve in his back? Do you see that curve in his thorax? That curve is typical of a right BC pattern. Right thoracic curves. Right thoracic curves. Convexity on the right, concavity on the left. That's side bending and rotation. Those are roto type of curves. Centering over the right leg. Centering themselves over their right central diaphragm tendon. Those curves are central tendons for orientation, Tessa. That little 14-year-old man is centering his body over his central tendon on the right side. And that's his sensory feeler. That's his bug antennae saying, that's where I belong. Shoulder blades rotate up, rotate forward and inwardly, drop, and rotate in an abducted state. All that is in your manual. I'm going to move through this section a little faster because you have it in your manual. So on page 43, what we did, and I'm going to show you the right and the left here. I'm going back and forth. We have outlined what the left shoulder blade will do and the right shoulder blade will do. We could literally spend 45 minutes on the terminology, I'll use the word, verbiage, on these two scapula. And you wouldn't walk out of here any more clinically successful than you were before I started it, if you didn't know how to manage what's under it, the thorax. So in a right BC pattern, on the right side and left side, you're going to see shoulder blades do two different things. Now, this shoulder blade on the right side and this shoulder blade on the left side, are outlined by looking at adduction, downward rotation, external rotation, and how you rest. Everything on here is going to be reversed on the right side. Not everything, but close to everything. On the right side, which is the side I'm going to concentrate on. I could easily concentrate, Susan, on the left side. I could easily do that. Keeping in mind that eventually your brains are going to shut off with all this information. Okay? If they already have not. So all I'm saying, I'm just going to cover the right side right now, and you'll understand why if we get the right side to work, what you then could go back and look at is going to improve what the left side cannot do or is stuck into. On the right side, you're going to see an arm more abducted, not the arm, the shoulder blade, depressed, and it's secondary to the thoracic orientation. It's translation. It's translation. It's slippage. Remember the acute angle of the rib, that little hump back there? You don't have as much surface keeping your shoulder out and up, especially if those bones start to change over age. So you translate easier on the right side. You go forward. Your shoulder blade rotates up, and it rotates. This glenoid comes forward, and it rests in a protracted state. In other words, it's resting on a little bit of a rib hump. It's kind of a little bit slightly protracted. And with protraction means it's slipping forward. It looks like it's going forward. It's also has some retracted state issues as well, coming from the position it's in. It's going to wing a little bit. The subclavius component's going to kick in. And you'll see that with a lot of patients. This is the typical pattern. Flatter back, rotated up, translates forward, depressed looking shoulder. Jen, do we have the classifications of the shoulder in the appendix in this course? Is that the I&I course? Okay, so I won't talk about it. But basically for years I kind of liked these shoulder blades. I kind of classified them, talked about them. And I would just call this a typical right BC pattern because of the abducted, upwardly rotated, and depressed look to it. Now if I lay you on your back, the top row is going to be familiar. But if I stand you up, the bottom row is going to be familiar. So if I stand you, you basically got to come up. You'll be upwardly rotated. You'll be slightly internally rotated, protracted, and depressed. And then the left side is outlined in your manual. It'll be almost the reverse of what you see on the right. So you can see this individual here has a chest wall. He's got a slight curve to the right, slight, flat back. This scapula has something to rest on, and this scapula is begging for something to rest on. Okay? Does that make sense? You guys all see that a little bit? Right arms could look a little lower than obviously Rick on the left. You'll often see people put their thumbs and their hands in their pocket. They'll walk as if they were in their pocket. They splint. We kind of showed you that yesterday with somebody walking. Okay? All right? You yawned, and then he yawned. Isn't that amazing? What do you guys got something over there going on that table? Right? Okay. It's just amazing. I looked up, he yawned, and then the next second you're going at it. That's kind of funny. Here we go. Page 45, neutral pattern. This is the front view. When we get you in a neutral position, those glenoids are out there neutrally. You stand them up. They may change. What's going to impact them? Possibly gravity. Gravity could influence the way you hold those two shoulder blades. And on the right side, the rib cage is going to be slightly more forward. So we put you on, this is a little foam pad or a cardboard box, just to get everybody to understand this particular right shoulder on a right BC patient is going to be more forward because possibly of a rib hump. Now, what do I mean by forward? It's going to be pushed back, but it's going to be forward because it's sliding. But the entire thorax is going which way, everybody? Further what, Rick? Don't answer the question, posterior mediastinum. Further back. But on the left side, we're trying to create posterior mediastinal function by getting the left side to move back while at the same time the right side is moving forward. And that's the outline of what we're trying to do with these techniques. Here's another picture that was sent to us. You can see again the lights shining upon them with a pretty good, nice angle at the angle of the medial border of the scapula more upright, more translated forward. It's a little misgiving. It looks like it's downwardly rotated, but if you look at that glenoid from the front, it's actually going to be tipped up a little bit because of the translatory motion of the scapula. Nonetheless, you should be asking this question later, but I'm going to ask you to ask it today at this point. Why would you put someone through a right low trap and right tricep program that looks like that? Well, first of all, they don't need right low trap and right tricep here. So what would you have to first do to give them any program for the scapula? What's the word yesterday? Reposition. Once you reposition this person, because they've been in that state for so long, what muscle did they shut off in that position? The right low trap, the right serratus. Now, Jen's right. We're not going to kick in a lot of right serratus today. We're just going to make sure serratuses are kind of keeping us on the rib cage. But this is going to be a left serratus day. The right serratus is just keeping us on the rib cage. What's the left serratus going to do? Rick, you know the answer. Achieve a what? Just say what we said this morning, Rick. Yeah, you do. Left, posterior, mediastinum. No, we're going to start back up. But left, posterior, mediastinum. What's the left serratus going to do for us, guys? Establish a left, posterior, mediastinum. On the right side, the right serratus anterior, Rick, is going to help us stabilize the scapula on a newly opened, positioned chest wall that has more air going into it. That's the right one. And this guy needs right low traps and right triceps after you get that chest wall to what? Open up or reposition. I hope nobody in this room ever thought I was picking on them. I'm just trying to stimulate thinking, discussion, right? So right thoracic expansion is what we got to get, Linda, before we kick in that right low trap and right tricep. So this is before and this is after. So Mike's done a good job. And Mike sent that because he teaches this course and he's saying to you, this is what a right low trap and what a right tricep program did for my patient after he got air established on the right side. Jen, did I do okay with that? Okay. On page 45, we then took you through what it would look like if you were looking from the top down and then from the top front oblique view. And again, for today, I just want you to understand the manual is a great reference center. You can look at it, and Chris, it'll make more sense to see with 3-dimension what's going on. If we were really high tech someday, it'd be kind of cool because we'd actually change it right in front of your eyes. But right now, that is called left trunk rotation. Left trunk rotation. That's 1/2 of the gait cycle. Right trunk rotation would be just Susan the reverse. You're only seeing left trunk rotation. That's the right BC pattern. Does that make sense to everybody? If we were really complete, which I don't want to be in this manual, and I showed you both sides, you would go home saying, what's the take-home message? Take-home message is, you're doing that a lot. We're doing that quite a bit. We want to change that. We want to get to go the other way. Okay? This morning, I showed Jonathan's inability to fully move a humeral bone because he could not, because he was in a position, he was placed in a position that wouldn't let him do certain things. One of the things they would not allow him to do was horizontally abduct. And this is a good way of looking at the limitation from the top angular view with respect to where the neutral position of that arm would be. Remember, it looked like he can't horizontally abduct, but that's an opinion based upon the fact that you assume he's neutral. On the left side, neutral should be down. Do you follow me? And he should be already there. And because the position he's in, he can't get there because I'd have to test him with his arm up and down to the bottom to get the horizontal abduction I'm looking for. And